Thanks for joining us today. Not sure, I think Jonathan may join at some point to say hello. Listen, I'll just start out by saying I know we're all in this very strange time, and I want to assure you that AMCHP staff are safe. There's only a few people who live in the district, but everyone's staying safe. Obviously, we have some other partners on the call who are in the DC area. So I'll just say that's obviously overshadowing all of our moods. And we hope that you're all safe as well. I see Jonathan has signed on. So maybe, Jonathan, can I turn it over to you for a moment to say a few words?
Yeah, Amy, thank you. And apologize for joining a couple minutes late. I initially just wanted to jump on for the first meeting of the new year and say Happy New Year to everyone. I hope everyone had some time, much needed and well-deserved time with family and friends, and were able to spend time with your family in a socially distant and COVID-friendly manner. And just to thank you for all of your hard work and effort in 2020. As I've said before, this pandemic has caught us all. It's unprecedented. It's caught us all and put us all in a pretty bad position. But it could have been much worse if not for the response of many of you on this call and our leadership that's on this call, and those who were just able to respond in a way that really prevented this from being much worse. Even though we've had experienced loss as a community, and it's probably lost within our families and our hearts, and our thoughts and our prayers go out to all of those that have. I still believe that it was as a result of your efforts and people like yours who are working on behalf of your constituents and the communities you serve. We're in a much better place than we could have been. So thank you for all of your efforts in 2021, your sacrifices in 2020, excuse me, your sacrifices, putting yourselves in harm's way in many cases for the good of the communities that you serve. And just Happy New Year, and looking forward to a better prospect and outcome in 2021. As I heard sort of Amy touching on a little bit earlier, I do want to just allow time and space to do a bit of a check and let folks know that you're in our thoughts and prayers for all those individuals who were impacted by yesterday's events, whether directly or indirectly. I know there are a lot of folks that live in the district, and I personally was in between meetings, and I just happened to turn on CNN to take a look at how things are going with the normal order of the day, and saw what was unfolding on the Capitol lawn, and was really taken aback by it, disheartened, disappointed, discouraged. I still don't know if I've fully come to grips with everything, as I'm still unpacking it. So I don't know if I will be able to address it as eloquently as I hoped I would be able to. Just to say that I've been praying for our country, and praying for all of those people who were directly impacted by what was taking place yesterday, and those folks of us who were indirectly impacted by it, because I can imagine if you were like me, there were a lot of emotions that you were experiencing and feeling as you saw things take place yesterday, and even now as you're still processing and coming to grips with what you saw. So I do hope, my prayer has been that that through all of this chaos, confusion, discourse, that there's a brighter day ahead, and not simply because of administration changes, but because as we look to the occurrences and experiences of the past, that we learn from our experiences and grow as a people and as a nation, and begin to interact with each other in a much different way. And that's not limited to politics, red, blue, or anything. That's hopefully as our hearts begin to change with what we see and experience, we begin to do better and treat each other better. So that's been my prayer as we move forward. So I hope that we will as we process this, you'll share with me in the optimism that is our future. And I just wish everyone well in the coming months in this year. So thank you, Amy.
Thank you, Jonathan. So with that, we will go forward with our regular schedule. We have a lightish agenda for today. I'll start with a legislative update. We have an update from MCHB. Unfortunately, our CDC colleagues couldn't join us today, and hopefully they'll be able to in the next call. And then we'll make you aware of some translation services available by AMCHP for COVID-19 information. And we'll give you more on that towards the end. So wrapping up 2020, thankfully the end of year package was signed into law on December 27th, just under the wire. It's been affectionately called the Stimnibus because it's been a combination of stimulus and omnibus and everything else. But most importantly, it does fund the government through the remainder of FY 2021, averting any threat of a shutdown. And then I wanted to highlight, of course, the $25 million increase for the Title V Maternal and Child Health Services Block Grant for a total of $712.7 million in FY 21. And I know Dr. Warren is going to cover this a little bit more in his presentation, so I didn't go into further detail. I also want to make note of $8.75 billion to support COVID vaccination. And actually, between when we prepared these slides and loaded them and now, I did just see, and it might have been sent out yesterday, but the CDC has released the allocations for states for increased testing and also for vaccination efforts, which we know was sorely needed. And as we've seen with the rollout, it's much welcomed. So hopefully that will be making its way to you all soon. There was also some unfinished business at the end of the year. We had been working very hard on a number of pieces of maternal health legislation that we really came very close on. And unfortunately, at the last moment, there were new objections that hadn't been raised previously. So in the end, we did not see passage or rather inclusion because anything that was going to be passed had to have been included in that Stimnibus final year package. For the postpartum Medicaid extension, for Maternal Health Quality Improvement Act, which would have authorized a few maternal health, public health programs, or more broadly, the bills that had been included in the Black Maternal Health Momnibus, which we have supported. Also, at various points during the year, when different iterations of COVID relief packages had passed the House, there had been supplemental funding for Title V and for MCHB, the Maternal, Infant, and Early Childhood Home Visiting Program. Neither of those were included at the end of the year either, once it became clear that the COVID relief portion of this legislation was going to be much more pared down from what had previously passed the House. I call it unfinished business because it's not over until it's over, and these are all things that we're going to continue working on in the coming year. I put a little, thumbnail of the letter that AMCHP led that had 115 signatories from different organizations, asking Congress to pass the postpartum Medicaid extension and the Maternal Health Quality Improvement Act. There's a broad bipartisan coalition who want to see these bills move forward, and we are going to keep on working on it. We know that oftentimes, it takes several Congresses for legislation to be passed into law. We thought we were getting luckily very close last time, and we're going to keep at it. Similarly, on MCHB and Title V funds, I will say MCHB also, before we know it, is due for reauthorization as well. So that's also top of mind as we're preparing our efforts for the coming year. Looking ahead, so there's going to be a slim Democratic majority in both the House and now we know in the Senate as well, which means that the legislation that gets through is going to have to be very well massaged and agreed to before it even gets put forward for a vote. But hopefully, again, there's a lot of legislation that I was just mentioning that had been left unfinished in the previous year that a lot of bipartisan work had gone through before. Maternal health and child health issues are seen as issues where we really can work bipartisanly and are seen as priorities for the new administration. So we are hopeful. And I wanted to also mention that while the Senate is still seating committee members, 2 new members of note, or I should say 2 newish members, they were both elected originally to Congress in 2018, but have now been placed on very powerful committees and I think could be great allies for the work that we're doing, include Congresswoman Kim Schreier from Washington, who's actually a pediatrician, and on the Appropriations Committee, Lauren Underwood, who of course is co-chair of the Black Maternal Health Caucus and was one of AMCHP's Legislative Champion Award winners last year. So we're really excited to see MCH allies taking positions on these powerful committees. I also want to make sure that you all are aware that AMCHP did send a document of maternal and child health priorities for the new administration. I'm just gonna, kind of show it to you quickly here. I know it's probably hard to actually read what it says, but this is just to give you an idea of how we framed it. So we, tried to emphasize why maternal and child health should be prioritized. And then we broke it down into categories around addressing racism as a public health crisis. We know we're not going to make any progress on any of our priority areas unless we address this root cause of severe inequities in the system. And we also highlighted the prioritization of MCH populations in the context of COVID-19 and other emergencies, and talked about what Title V and MCHB can do for these programs, as well as the surveillance for emerging threats to moms and babies program at CDC. Chasing Zero, the driving down maternal and infant deaths, which is right out of AMCHP's strategic plan, and of course, making systems of care work for children and youth with special health care needs and their families. And so I do have a link here, it's online, to read the full document. We shared it right before the holidays, and so we'll probably circulate it again. It has been shared directly with the administration, of course, and was acknowledged that it was received. So hopefully there's people in charge who are reading it. But we've shared it on social media, but we'll try to share it again more broadly, just waiting for the right moment. And this week's probably not that time. So, but thank you for the support. So please, feel free though to link to it in your social media or other publications that your organizations or partners might circulate, listservs, newsletters, etc. Again, the link will be available again when you get the copy of the slides, but it's also on the AMCHP website and has been shared on our social media. And with that, I'm going to turn it over to Dr. Warren. So thank you, Dr. Warren.
Thank you, Amy. Thank you to both you and Jonathan for your introductions. I also want to acknowledge the events of yesterday and want to first thank folks. Several of you on this call reached out to check on folks who were in the DC, Maryland, Virginia area, and that's much appreciated. Our MCHB staff who are here in the DC area are all safe and well, and appreciate your thoughts and well wishes. Also want to acknowledge, and Jonathan alluded to this, the trauma for folks who weren't even there, trauma with the experiences they were witnessing yesterday, but also trauma from thinking about the events of yesterday in context with events from the past year and differences in response to that, and really underscoring the tremendous work that we still have before us as we work for that more perfect union. And so we are glad to be on that journey with all of you, and as we keep equity at the forefront of all that we do. I also want to acknowledge, before I jump into the slide presentation, many of you know that Michelle Lawler retired at the end of December of 2020 after serving for many years with the Maternal and Child Health Bureau, and she had an impressive career in state public health before that, or local public health before that. But Michelle retired at the end of December, and I want to acknowledge that Christopher Dickton, who has been the Deputy Director of our Division of State and Community Health, has graciously agreed to be our acting director of that division as we make this transition with Michelle's retirement and look ahead to recruiting for a new permanent division director. Chris is fantastic. Many of you know him and have worked with him in his role as deputy. He knows Title V up and down. He is so open to thinking about how we support the states and jurisdictions. And I can tell you, he's a big advocate for you anytime we're at the table, making sure that we always remember the state perspective. So if you have the chance, give a shout out to Chris and welcome him. And we appreciate him stepping up as acting director during this time. So I wanted to share a few updates with you. If we can advance to the next slide. The first, as Amy mentioned, exciting news just before the new year with the passage of the full year FY21 budget. We in MCHB got an increase of $31.5 million. You see our 11 different legislative authorities there. I'll quickly highlight ones where there was an increase, and then I will point out some more detail about some of the lines in particular. So in the maternal and child health block grant line, there was an increase of 25 million. That block grant line also includes SPRANs and KISS. So we'll talk about that in just a moment in more detail. There was an increase of 2.5 million to Healthy Start, 1 million for autism, 1 million for heritable disorders, and then 2 million for the sickle cell treatment demonstration program. You will see on this slide, we don't have figures listed for MCV and for family-to-family health information centers. Those are called mandatory programs. So when those are authorized every few years, the appropriation for those programs happens then. So they're in our overall budget, but they weren't included in this bill because they've already been funded through their authorization periods. Next slide. So diving into some more of the details. So I mentioned $25 million increase to the block grant. So for the state formula grants, that's an increase of $5 million. That $5 million, we will apply the existing formula for the block grant funds as we're required to do by law. And so you will see those increases over the course of this coming year in those notices of award that you get. There was also an increase of $20 million to SPRANs. SPRANs is our special projects of regional and national significance. When that was originally envisioned years ago, when the various categorical programs were converted to a block and SPRANs was created, the intent is really to address those special and emerging issues or issues that are of importance at the regional or state level. Over time, what we've seen is that when we get increases in the SPRANs funds, it's not just do anything you want with that money. It is intended for a specific purpose. And so that increase of 20 million is actually all spoken for in the appropriations language. And we'll talk through what those purposes are. There was also flat funding for what we call KISS, the Community Integrated Services System. So that funds things like some of our children with medical complexity, COIN work, as well as some early childhood comprehensive systems work. So that piece was flat funded. So within SPRANs, there were increases that we'll talk about in just a moment. But in our other lines, autism, there was the $1 million increase that was specifically called out as an increase for the LEND program. Within Healthy Start, there was a $2.5 million increase. There was also a continuation in the last few years. Healthy Start has gotten some additional funding to build clinical capacity within Healthy Start sites, and that funding was continued in this budget. There was $1 million for the heritable disorders. And then with sickle cell, $2 million for our treatment demonstration program, and then additional money set aside in SPRANs. So on the next slide, these are some of the SPRANs highlights. So of that 20 million we got, just giving you an idea of how that's allocated. So 7 million of it was for maternal health. There was an increase for AIM. We previously had $5 million for AIM. We got $4 million additional dollars, so a total now of $9 million. And there was also new in our budget, $3 million for a maternal mental health hotline that we're required to do by contract. So our team is exploring the options for how we do that there. There's also $10 million within SPRANS to create a regional pediatric pandemic network in response to the needs that we've seen in pediatric preparedness as part of the COVID pandemic. And there was also $1 million for a study on adverse childhood experiences, looking at how we implement screening protocols and interventions, and eventually identifying models that could be replicated across settings. So those are all new increases. And as I mentioned on the previous slide, there was a $2 million increase in SPRANS for sickle cell as well. Within our SPRANS budget, we got continued funding for infant toddler courts, for the Children's Health and Development Initiative, and then State Maternal Health Innovation Grant. So we were grateful for continued funding across a number of areas, as well as some new funding. We'll go to the next slide. And I know that's a lot, so if you've got any questions, feel free to chat them in, and happy to try to answer those or to get an answer back to you. So not in the budget per se, but in some of the text that goes with it, there were some additional provisions around MCHB, and because MCHB is housed in the same agency as Title V in many states, and regardless you are coordinating with MCHB, whether they're in your agency or not, we wanted to make sure you were aware of some of these provisions. There's language in this Appropriations Act around virtual home visits, saying that a virtual home visit shall be considered a home visit. We know that many local implementing agencies had to switch to virtual visits early on. Many are still doing that, and so that counts as a home visit. That there's a provision saying that funding and staffing levels would not be reduced due to reduced enrollment. We know that enrollment can be a challenge during these times. And there were also some provisions around what funds can be used for. So training home visitors, acquiring technology for families, and providing emergency supplies to families that are served. The legislation also explicitly defined what is a virtual home visit. So all of these provisions are helpful. They are responsive to the needs and concerns that we have heard from MCHB grantees and stakeholders over the course of the past year. And our team in MCHB will be communicating these in much more detail with state MCHB programs in the near future. But wanted you to have a heads up, given the close connection between Title V and MCHB. Next slide, please. So I wanted to spend a little bit more time talking about the new P4 challenge, promoting pediatric primary prevention. We've talked about this with you all before. You'll remember this is our prize competition that was prompted as we saw the decrease in childhood vaccination and well child visit rates as a result of the pandemic. And so we were able to set aside $1 million in cash prizes. This is a great example of something that we fund out of SPRANS, those special projects of regional and national significance. And the money will support prizes for innovative approaches to either increase well child visits or immunizations, or both. We are encouraging partnerships with state and local organizations. One requirement is that the applications must include a primary care provider who delivers healthcare services to children. So we really want to recognize the primacy of the pediatric medical home, a long-standing item of importance for MCHB, and we will continue that with this challenge as well. You have heard me say before, these challenges are a whole different kind of competition compared to the grants you usually apply for. So very low bar for participation. It's a 3 to 5 page application. So not a 60 or 80 page application like you're used to. Very brief and to the point. The goal is to get people to apply readily and to engage partners who might not otherwise apply for HRSA or MCHB funding. I want to share on the next slides, the next few slides, some examples of ways that we see this connecting with your work. And so our team in the Division of State and Community Health did a fantastic job of diving into the Title V information system with the latest and greatest information you all have through your block grant reports and applications. And we looked at where we've got priority measures or priority designations or performance measures, I should say, that relate to this P4 challenge. So for example, 5 states have marked immunizations as either a state priority or a state performance measure. So Idaho looking at improving childhood immunization rates, and they've got a state performance measure along with that. North Carolina looking at improving immunization rates. They also have a state performance measure, as does Palau, who has a priority around childhood immunization. So if you're in one of those states, or if you're in a state that has a related priority, this is a great opportunity to go back to your needs assessment data and look at what drove you to that priority or that measure in the first place, and think about, are there particular parts of your state or your jurisdiction that you want to partner with? Are there particular entities that you want to pass this information along to? You may not want to tackle this project, but you may want to get them involved, or you may know somebody who would benefit from the prize money and benefit from the population health improvement. So immunization are one of those areas that would benefit from this work. Next slide. You'll also see that medical home gives you a great opportunity to think about tying back to this P4 challenge. So 39 states have medical home either as a priority or report on the national performance measure, the NPM 11, related to medical home. So Georgia, Nevada, Tennessee, Texas, looking at some of those elements of medical home, both for kids with and without special health care needs, looking at some of the specific components like comprehensive, family-centered, coordinated. All of those give you opportunity to tie back to this P4 challenge. So again, maybe you're working with provider organizations, maybe you're working with your F2Fs in your state or other community-based organizations that serve families. Great opportunity to engage them and think about working on this challenge. Next slide. The other area that jumped up was this notion of adolescent well visits. So you all know our national performance measure, NPM 10, relates to adolescent well visits, and a number of states have selected that as a priority. So Delaware, the Federated States of Micronesia, Kansas, North Dakota, all have something related to adolescent well visits. And so in those states and jurisdictions, again, a great opportunity. Look at your needs assessment, think about what drove you to select that priority in the first place, and where might there be some opportunities to think about incorporating this either into your action plan and part of the work that you're doing, or thinking about disseminating this information to your partners throughout the state. Next slide. So just a few details around this to share. The website is listed here, and folks can go and get all sorts of information about how the challenge works, who's eligible, what the activities are, those kinds of things. The submissions will actually open on January 19th. The website is live now, but we'll start accepting submissions on January 19th, and those are due by March 15th. So folks have got about 3 months to get that done from the time we first announced the challenge. We plan to select up to 50 phase 1 winners. Those phase 1 winners will be judged based on the 3 to 5 page application that they submit. So again, very low bar to entry. And just for submitting a good idea that's selected, those folks will get $10,000 to use for their work. We will then take a 6-month phase 2 project period where folks will implement the plan that they submitted that was selected as a winning application. They'll implement that plan with their partners. They'll then report back to us on how they did. What was their performance? How did they partner? Were there any innovations, lessons learned that might help us scale this work up? And from those, we'll select 20 winners for phase 2, and those folks will get $25,000 each. So folks who are successful in both phase 1 and phase 2 will win up to $35,000. So a great opportunity for some meaningful support, particularly for community-based agencies. So encourage you to visit the site. Please share it broadly. We're sharing it on HRSA social media, but also think about how you can share it in your networks, either amplifying those messages or sending out your own notes, encouraging people to be engaged in this work. Next slide, please. I wanted to wrap up today by planting a seed. Certainly many of you are involved with your states in the COVID-19 vaccination efforts for healthcare workers, for residents of long-term care facilities, for essential workers, and then moving into the general population. We know that there will eventually be a vaccine for children. So right now, one of the vaccines goes down to 17 and 18-year-olds. But certainly in the future, there will be vaccine for younger populations. And so similarly for pregnant women. And so we want to think about how we look ahead to that time. We don't want to wait until that happens and then think, what questions do we have, or what are the things we need to think about? So I wanted to plant a few questions for you to think about, and feel free to type those in the chat box, your responses to those in the chat box. So the questions we have are, what are the roles that you see for Title V agencies in vaccinating MCH populations? Some of you may already be connected with efforts, or you may not be, because the focus has really not been on MCH populations thus far. So what do you see as the roles for Title V? What are the challenges you anticipate? So what are the things that, maybe given your prior experience with regular vaccine work in this area, or maybe given your work over the last month or so with COVID-19 vaccines for the priority populations, what can you anticipate as being challenges for MCH populations? And then finally, what would help you be most successful in assuring MCH populations in your state are vaccinated? This is where we're trying to better understand what support might you need, and what ways can we be of assistance to you, or connect you with folks who can be of assistance. So those are the key questions. Again, if you can type those in. Alternatively, Jess is telling us folks can unmute and respond to those questions verbally. So if you'd like to do that, I will let Jess and the AMCHP team handle that. We'd certainly be happy to hear from you. But bottom line, we want to understand what you're thinking about this, and what you see as roles and opportunities, challenges, and where you might need some help. So that's it for me in terms of updates. Happy New Year to all of you. We are so excited to be looking ahead to 2021 and continuing to be able to support the fantastic work that you're doing. And just thank you so much for the tremendous work you did in 2020. You know, I could imagine sort of looking back in a normal year and saying it was a needs assessment year, and so we went through that whole process, but needs assessment seems like the least of our worries given all the things you've navigated in the past year. So thank you for all the ways you've supported MCH populations in your state, and we'll look forward to working with you in the year to come. So again, if you want to type these in or unmute yourself, Sarah Leff is talking about local Title V funded agencies can think about community engagement and messaging, and notes that it would be helpful to have vaccine messaging materials specific to maternal, child, and adolescent health populations. Thank you for that. That's exactly the kind of thing that we're looking for. So thank you, Sarah.
Thanks. And I can, wait a minute before we move on if anyone else wants to chime in. And I'm so glad Sarah brought that up. I was on a call where some partners from other organizations were getting briefed by the CDC's team as well. And I don't know if anyone from CDC is on, but I'll call them out since they weren't presenting today. One of the things that was interesting to me was sort of the timeline in developing communications around messaging, and realizing that the messaging efforts that are going to be needed to be geared toward, or this is something that occurred to me, parents, when they're making decisions about their children, is different than the types of messages that might be being developed right now in terms of, encouraging people and health workers to, people, the population in general, but, specifically health workers, et cetera, who are first in line to get their vaccines right now. And so just thinking about what an important role our membership can play in providing advice on, we're the ones who are used to communicating to these populations. So
absolutely. And I think thinking about the trusted voice that MCH programs have, and state public health and local public health has, I think also you all have this awareness of being mindful of trauma and of hesitancy, and the understandable hesitancy that folks have around vaccines, particularly where there are questions about trust. And so thinking about how we work to regain some of that trust and address that through messaging. Some of that comes through, we're seeing some questions about overcoming the novelty of this type of vaccines and fears of patients and families, messaging around efficacy and safety. So all of those things we can think about how we partner with folks, whether those are other federal agencies or some of our non-federal partners who've already done some of that work, and think about tailoring those messages to MCH populations. There's also a question that has come in about knowing if we can have staff positions that are HRSA funded to be able to provide vaccine support or work the vaccination effort. We always want to hear those questions from you. And so I'll put Chris Dicton on the spot. Chris, I don't know if you want to say anything about the folks who are block grant funded. We can certainly, for our other grants, I would say, please engage your project officers. We will talk with the division leadership across the Bureau to make sure they're ready for those questions and to be able to respond. But Chris, I don't know if you want to say anything about use of block grant funds for that.
Should be able to unmute himself, I believe.
I don't know if Chris is able to unmute. I would say, one, think about your the various buckets. So certainly the primary and preventive care for children bucket, COVID related things could apply there. Also generally the flexibility of the block. A general good rule of thumb is making sure that we're meeting our 30-30-10 criteria. Those are pretty broad. And so if you've got questions, your project officer can help you navigate those. But generally there's a fair bit of flexibility in the block, and we are always happy to help think through that. If Chris can't pop on now, we'll certainly make sure we follow up with you all with the answer to that question. But similarly, if you've got that question around MCHB or Healthy Start or EMSC or others, we're happy to answer.
Not sure if you saw, there was another message I think that just went to panelists about. Oh, sorry, I was reading another question about messaging to address anti-vaccination population. Becky, please continue with your question.
I was just going to clarify, because I think it's actually more about MCHB staff, because right now the MCHB staff are being asked, because they're nurses, to potentially they're going to be activated to work the vaccination effort as we get vaccines released. And every time that they're not seeing clients, we're not getting revenue, some of our TANF revenue and other sources. So we're really watching that closely, but we also know that needs to be funded via COVID funding and not via their HRSA MCHB funding. So I think we're just trying to figure out what if federally there's going to be flexibilities built into these funding sources as we do the large scale rollout of vaccine as it reaches the general population.
Thank you, Becky. And if you haven't already, if you'll send that question in to us so we can make sure having that in email is helpful too, and we can get that routed to the right folks in MCHB. Again, if you haven't already done that. One of the, what's that?
We did. We submitted a couple of days ago.
Perfect. I will reach out to them to make sure that is in their queue to respond to. One of the things that is a little bit different around MCHB, not to get too wonky. So we've got the block, which I sort of think about as being uber flexible in terms of the things in our budget lines. We've got many of the other legislative authorities that I showed you on that first table, sickle cell, newborn hearing screening, those kinds of things that are funded out of the Public Health Service Act. And in the Public Health Service Act, there's actually a provision that allows temporary reassignment of personnel. So if there's a public health emergency, states can request through the secretary that folks who are assigned to those grants and paid for out of those grants be temporarily reassigned to something like administering vaccines. And they actually are still paid for out of those grants, but they're doing that. MCHB, unfortunately, doesn't have that provision. And so it is not for a lack of interest on our part. We absolutely recognize they are an important part of the public health team. And in some cases, they're nurses. And so it actually be able to give vaccines. Right now, the way that law is written, we don't have that flexibility. But every time we have those requests, it's helpful where we have the opportunity or where partners have the opportunity to make that case for us so that we could get that flexibility moving forward. So we'll look at the question that you sent and see if there's any flexibility, and we will also use that to help make the case when we have the opportunity when we're asked again.
And thank you, Allison. Can I ask you to share that with all panelists and attendees? And I realized when I updated the slides, I forgot to put the housekeeping slide in this week. So to remind you all to, when you try to send a message in the chat, to click on the all panelists and attendees so that everybody can see it, because I think that's a great resource you're sharing. And a reminder, of course, that this call is being recorded 40 minutes into it. Great. Well, thank you for making that available, Dr. And I know this is going to continue to be something that AMCHP ourselves are working on as part of some of the other funded projects that we have going on right now and responding to COVID. So really appreciate the opportunity to share these ideas. I do want to give a chance to my colleague Paige to let you know about an opportunity from AMCHP. So Paige.
Yeah, thanks, Amy. Hi, everybody. Actually, really timely and following this discussion, so I'm glad to have the opportunity to chat with you all briefly. So AMCHP, through funding and partnership with the CDC, is obviously very committed to supporting state and territory Title V maternal child health and children needs special healthcare needs programs in protecting and addressing the needs of MCH populations as all of these broader COVID-19 response efforts continue. Specifically, AMCHP has really recognized the need for our members to target communications to populations at greater risk for serious disease because of longstanding systemic health and social inequities. So that being said, we're really excited to share with you all today that AMCHP is offering no-cost translations of COVID-19 health education and other public communication materials into virtually almost any language other than English, working with a great contractor that has the ability to translate into, I don't even know the number, it's that much, languages. So I've listed here some of what we're calling, what would be an ideal material. We're thinking, preferring short documentation, 1 to 2 pagers that you have potentially already developed in your program. And we've created some criteria and I'll list it out specifically, but it's also up here on the slide. For materials to meet the criteria to be translated through our funding, must meet the immediate information needs of individuals and families currently being or those that potentially could be served by state or territorial MCH programs. The submissions for funding must be submitted by state or territory Title V MCH programs or affiliated organizations. We're defining affiliated organizations as organizations that receive Title V funding. So we know that that is different in every jurisdiction. So if you have questions about that, we're here to answer those, but that's really the key, is that they are receiving Title V funding. And the documents must originate from either the state or territory Title V MCH program, or again, those affiliated organizations. So for example, we're hoping to support you all in documents that you've created for the general population, but have noticed that, I know that many months ago, we talked about the specific communication needs for the Haitian Creole community with COVID-19, specifically in Maryland, but I know that that's elsewhere. So thinking, if you have created a document for communication of COVID-19 resources, et cetera, in English, and you would like to get it translated into Haitian Creole. That's an example. So it's something that you yourself, the Title V program or the affiliated organization, has created, not submitting to have a CDC document translated into another language. That's an example of something that wouldn't fit the criteria. So we have a request form, and I'll pop that in the chat box here shortly. And the form is pretty self-explanatory, but it does include that list of available translation languages. And we'll ask you just a few questions about the dissemination and potential reach of the translated materials. And, you know, obviously we want to take a look at what your plans are for disseminating, and make sure that it does meet this criteria so that we can be fair across all programs. I will say that things are a little tricky in that we can't guarantee, but we are going to strive to at least look at or consider one application per state or jurisdiction for translation. This is really difficult because different languages, the translation cost differs, so it's a little hard to you know, actually plan for how many, a set number of translations that we could get done. So we have a set amount of money set, for this project, and so we, you know, want to encourage everyone, each state and jurisdiction, to you know, at least submit one. I think as resources allow, there might be the opportunity to receive more than one translation, but we do want to try to be as fair as we can given the circumstances. So it is a tiny bit tricky, but we'll work with you on that. So if you go to the next slide, Amy, I did come up with our staff just a few examples. Again, that might help you think about what would, you know, fit and be a good resource to submit for this. And just a tiny bit more about sort of the reasoning behind this is that, you know, what we've heard and what we know is that you all will continue to need materials translated in a time frame that sometimes government agencies cannot always support. So by AMCHP doing it, we hope that will really speed up the process and continuously encourage and get your program access to those priority materials, and then quickly turn around those translated versions before the material is obsolete. So this is, again, on a rolling basis. I think, you know, as we were just talking about with Dr. Warren, there might be more of a need for this once vaccine rollout continues and is more, you know, for specifically the MCH populations. But again, there might be a need currently, and that's fine too. So let me drop the form in and just see if anyone has any questions while I'm here.
Great. Thanks so much, Paige. And we did put, you put Dorian's email, so that's great. So we certainly do encourage you to apply for this. I think it's a great, I mean, maybe I'm biased, but I think it's a great service that we're able to provide and are excited to. So, just as we were also talking about the importance of having maternal and child health focused communications. So with that, I'll leave it open for Q&A, but I do want to give you all a reminder. We will have our next call in 2 weeks, but after that, we will be moving to a once-a-month format in order to accommodate the Title V TA partnership meetings. We don't want to be responsible for overburdening you every other week. So we can revisit the frequency of these calls after April, but just keep in mind that February, March, April will only have one policy/COVID town hall. You can get the registration here. So we will have a call in 2 weeks on January 21st. And Jess has also plugged in that registration on the chat if you have any questions about that. So I'll just leave it open for another minute before we adjourn. If there's any other questions, thank you to everyone who chimed in with some really helpful resources and communications tools. And most importantly, stay safe. And I hope that we can look to better times soon. I don't know what else to say besides that, but that's how it certainly feels around here. Thank you all. Have a great rest of your day.